Good afternoon, everyone, and welcome to the Baldrige Foundation's Institute for Performance Excellence Virtual Executive Roundtable. Technology, maximizing your systems to accomplish your goals. Before we get started today, I want to take a moment to recognize all of our great sponsors and a special thanks to members of the Mac Baldrige Society who serve as trustees for the Foundation's Institute for Performance Excellence. And here's today's agenda. Today's guests include Roger Spoolman, facilitator and co-host of the Baldrige Foundation Leader Dialogue Program. Ben Sawyer, Vice President, Transformation Engineering, About Healthcare. Dan Mullen, Vice President, Innovation, About Healthcare. And Darren Versillo, Co-founder and Chief Medical Officer, About Healthcare. Their presentation will be followed by questions from the audience, moderated by Roger Spoolman, and a few closing remarks. So Roger, we're going to turn it over to you.
Great. Thank you, Al. And thanks, everyone, for spending your Friday afternoon with us. We've just come through Thanksgiving season and headed into Advent. And hopefully you are listening not just to kick back, but get fired up, because we can't, as we all know in healthcare, we never close. And so we've put together today's agenda to help you be energized and think about how you can best lead your organization. And I want to start by talking about this particular slide and the financial headwinds that we're experiencing. Now, this won't be a surprise to anyone of you who's participating on this webinar today. But as I look at this Kaufman Hall index, month by month, year by year, or year to date operating revenue, I look at it and a couple of things come to mind, and I'd like my panelists to also weigh in on this if you would. But October 22 represented another month of negative op margins. It's been a little choppy the last few months. We make some gains and we give them away, and we make some gains and we give them away. But you look back to November 2021, where Kaufman Hall says we had a 4.3% op margin. I wonder, it's my thought that November 21, December 21, I think those are inflated by CARES Act dollars, because things started shutting down far earlier than that in 2020. So this may be worse than it actually looks. And again, let me just remind you who our panelists are. Ben, as always, if you listen to Leader Dialogue, Ben and I, share that responsibility, along with Dr. Chuck Peck, who's vacationing today. Chuck is, but Ben is here, always insightful, great. He's a great researcher and studies these things. So I'd like to, we'll get some great thoughts from Ben today. Dr. Darren Versillo, a practicing hospitalist, and Darren always has great practical insights about how we really actually apply these things in the clinical setting, taking care of patients. And then Dan is with us as Dan Mullen, who is also with About Healthcare, but he has been on the payer side for much of his career. And so he has also really fascinating insights about how on the provider side, we can take advantage of the information that it resides on the payer side. So guys, what do you think about this slide? Do you have any thoughts about it?
Yeah, let me dive in maybe first, Roger, and just point out a couple things. One is, if the audience is looking at the items 1 through 4 on the left, it's clear that there is congestion and challenges of getting patients in, through, and out of health systems. And it has a direct impact to this marginal report. If their observed to expected ratios, like in 3, are going well above 1, that means that they're not hitting their DRG targets, and they have a lot of avoidable days. Avoidable day costs have gone up. Pre-pandemic, the norm was around $500 the last day. Now what we're seeing is probably for last day around $1,000 to $1,100. So though that is problematic, and it drops right, as you know, to the bottom line. I think the other one that jumps out for me is 5 and 6. So during the pandemic, when patients were staying, or you know, community was staying home because the hospitals were treating pandemic patients with COVID, they didn't just stop using healthcare. they found other places to get care. And when the pandemic began to reside, they didn't necessarily come back to the traditional way that they had sought healthcare before. And a lot of new non-traditional entrants have come into the market. So I'm speaking like Walmart, CVS, Walgreens, Amazon, et cetera. And these organizations are very savvy with direct to consumer service delivery, and they also have much less cost structure. I mean,
we thought prior to this, sorry, Ben, to interrupt, but in health systems, we looked at those folks earlier and say, well, they're just nibbling a little bit at our margins. They're taking huge gulps, aren't they? They're grabbing so much more than just the marginal impact.
Right. I mean, because a lot of what health systems have depended on forever is the primary care referrals from primary care providers to their specialty networks and to the hospital and so forth. But a lot of these new non-traditional entrants are taking that over, right? They're like the Walmart clinics and EVS and yeah, go ahead.
And Ben, what an important point. You look at number 3 and 4 there, and thank heavens as we look at this trend. I mean, Roger, you talked before about the back and forth, the gains and the losses, the give and the get. It's like the stock market, right? You look at the Dow or the NASDAQ, it's up one day, down the next, and back and forth, and you get your gains, you give it all back in losses. Thank heavens, at least on this graph, we've got a trend going back up towards zero, where we can maybe get back in the black again. But I look at numbers 3 and 4 in the context of what Ben was just talking about, and in my practice, and I'm based out of the Salt Lake City area. And right now we're seeing flu come in like crazy. I know we're seeing influenza all over the country, and it's putting significant pressure now again on hospitals with regard to capacity. Of course, capacity now is measured in nurses, not in beds. Right. And so there's this dance going on where it just happened to me last night. I was on call, and I went on for a night call. Literally within a few minutes of being on call, the ER called me up and said, hey, we got 4 patients we want to admit, and we're out of beds, meaning we're out of nurses. Right. They found another one about 2 o'clock in the morning, unfortunately, because that was something I had to handle too. But as soon as they have any capacity, they are immediately filling it. And here's the change in the landscape now. You went from overload during the pandemic, then you went through this everybody staying away and overstaffed, hemorrhaging money post-pandemic. Then you had the great resignation with all the nurses leaving, and now you've got mismatch of demand and capacity. And now we're seeing this ramp up in demand with the flu season. We haven't had a flu season for a couple of years because people have been masked up, but nobody's wearing masks anymore. So now we've got a flu season again, but we don't have enough nurses. And so, it'll be interesting to see what happens with this graph. And when you look at number 3 and 4, with hospitals struggling to admit patients, well, yeah, there's nobody to take care of them. And then that leads to the upstream effect of boarding in the ED or staying somewhere else where they need to be transferred from, or to Ben's point, seeking care in other places. And so this is going to create this cultural shift that, boy, we better pivot in the healthcare industry, because to your point, Roger, they are taking big chunks off the pie that aren't going to come back to us as the method and the way that people seek their care shifts away from hospitals if we're the hardest place for people to get their care.
Absolutely. Yeah, that's the choke point, isn't it?
And health systems to a large extent used to be recession proof because they were the center of the healthcare universe. That erosion that we're talking about is compromising that secure position. That's just unfortunately reality, but that's what the financial numbers here are showing us.
I'd be interested, Dan, maybe you have a thought about this. When we look at this graph, I would love to have Kaufman Hall or somebody project, how long it takes. You said, Darren, we're trending towards zero. Woohoo! But how long would it take, and is it even possible to think that we get back to 3 and 4%, given number 6 and number 5 and all these other kinds of things. What do you think about that, Dan? Sort of from your history with the providers. I mean, the payers.
I think when we look at where we're going to get back to, I think we can get there, but I think in a different way than we traditionally would. I think as we look at 3 and 6, I think those are going to be two of the key contributors to us getting back to where we were, in that we've got to find a way to get that length of stay back down to less than 1. We've got to find a way to get those patients out and get the new patients in to get the flow through the hospital. And I think being ever aware of number 6 is going to be key to that.
Yeah.
I don't want to steal Ben's thunder as we talk about some of the solutions to some of these opportunities, but as we talk about innovation, it's really getting more out of our processes to reduce that expense to offset those revenue numbers. And I think as we dig deeper into how to solve these problems with innovation and maturization, I think we're going to help solve some of these. But I think 3 and 6 are the key areas I'd want to focus on, with how do we get the patients through the process faster, and how do we use what we have to become more effective and efficient in getting those patients through from a cost perspective.
Perfect tee up. It just so happens that's where we plan to go. It's like you saw this in
Almost like I knew what we were doing,
That's
Roger.
awesome. Way to go,
Almost
man.
like we talked beforehand.
Yeah. So anyway, that's where we're going with this. And I just do want to take a second to address our audience and say, listen, we're having fun, we're enjoying this, but we want you to enjoy it and get the most out of it. So please, as Al mentioned, please send us your questions. We're going to have some ample time at the end of this to answer your questions. So please take advantage of our really talented panelists and get their opinions on things. So here's some insights that came to us from the Institute for Performance Excellence, from a virtual roundtable that they held. And these are some quotes. I love this first one. COVID really pulled out the ugly. They didn't necessarily pull it out and made it not less ugly. They made it so much more ugly, with COVID did, with all the things that were just mentioned by Darren and Dan. So we're doing things in the near term just to stop the bleeding. So we're sort of in crisis management mode and incentivizing retention. And again, Darren, you nailed that when you said, okay, just about the time we got properly staffed, albeit very expensive, the patients dried up and we couldn't get them in. So, our increased expenses, and we don't have, we've got plenty of staff to take care of not enough patients. And so, hard to get that right at the right time. Problems aren't unique, but they are more pronounced. And as Dan just said, we can't solve these problems with the same old workarounds. These are new problems and they require new solutions. What really matters is not the technology we use, but how we're changing, and we tend to react in healthcare. Absolutely. And we've talked about some of those observations. And then finally, it's like using a pipe with cracks in it. That's not the time to do the repair work. It's when the water volume is low, then you can, but you don't notice it then. We didn't notice it then. You put pressure on the pipe and all of a sudden, whoa, where'd that crack come from? And so we're struggling. We're really struggling with this. And it's our goal, again, as we said, to help you through this and find practical solutions to make our way through this.
Roger, I don't know whether or not I ever gave permission for you to use a picture of my plumbing for my basement, but and I especially like that one that looks like some pieces of wood strapped to that pipe. It's interesting because, as we talk about things like leakage out of our system, being driven by overload or perception of such, in the trenches, and I know we have a lot of people on this call and they come from a variety of different backgrounds, but I am sure that many hospital leaders are dealing with this trust that they have to have in their staff to make the right call at the right time. And when we're talking about capacity in a hospital, again, the nursing question, and you try to force more fluid through a pipe like that when it's already bursting at the seams, you're going to get leaks. But what if you shrink the pipe, which is kind of what we're seeing right now? We've got shrunken capacity, and we're trying to put, if only, the same demand through it. I think one of the problems that I've seen, and what I've dealt with not only as a physician but in my consultative work with about across the country, is, first of all, number 3, these are not unique problems. Everybody's facing these. So let's just own up to the fact that we're all dealing with the same problems across the board. But what trust that we have to have in our leaders in our hospitals, especially nursing supervision, when they're deciding whether or not they can take one more patient or three more patients, or they're shutting it down saying, we're at max capacity. I can't ask my nurses who are used to a 4-to-1 ratio to take 6-to-1 or 7-to-1. I can't put 4 patients to a single nurse in my ICU. And yet we've got 10 patients sitting in the ER waiting to come in for care. And if we don't get to them, we got to transfer them out, which is inconvenient for the patient, riles the doctors in the ER because it creates more work for them, loses revenue opportunity for the hospital and the healthcare system. It's lose, lose, lose across the board. And so just, it's one of those things where I applaud the organizations that are really sitting down and having meaningful conversations about safety for their patients, safety for their nurses and their environment, and are addressing these issues of capacity with trust and insight and visibility and data.
Yeah, so true. And just a quick example. I mean, my 94-year-old mom is in assisted living, and she's had some challenges. I visited her at her assisted living last night, and nobody in the common areas. Everyone is forced back to be in their rooms. They bring their food to them because COVID is running through the assisted living. And I said, well, how's the staff doing? Oh, and the girls were talking about how, they had to pull extra shifts. And so what happens? That without innovation, without any kind of shoring up that end of things, people end up back in the hospital. And that's what happened. Several of the patients end up back in the hospital, making that situation all the worse. So this next slide after this one, unless somebody else wants to talk about that, but I want to get extremely practical, and as we said, we want to talk about innovation. And I have a client who's not a healthcare client, but happens to be in Europe, and in his organization, he says we're just not innovative. We have a group of people who are competent, but they're just all doers. Nobody's really innovative. And we talked about creating a culture of innovation in his organization. And back to what we said previously, you folks listening, you probably have not as much time as you think to really make some great changes, some significant changes. So not as much time, but on the other hand, you probably have more tools than you think you have. It doesn't take a lot of extra tools, and there are things that you can do immediately. So I'd like you guys to talk a little bit about this.
So maybe what I can do to start with, Roger, just for the benefit of the audience, is just kind of unpack what they're seeing here. And then Dan and Darren, if you guys can weigh in on your insights, that's fantastic. So one of the key things that you'll see in line 1 there is innovation by its nature is proactive, not reactive. In other words, you're looking to make meaningful change, not to react to overwhelming circumstances. And it doesn't mean that you're creating a product or doing something big. It's just meaningful change, right? It could be in your services, your programs, your processes, your operations, your healthcare delivery model, your use of technology, business model. But the purpose is really to create new value for your stakeholders, both internally and externally. And this is the guidance straight from the Baldrige criteria, which is, preeminent in terms of how you really innovate in your organization. Innovation should lead your organization to new dimensions of performance because of that proactive focus. And it requires a supportive environment. In other words, you have to create an environment where there's a process for identifying those strategic opportunities and the pursuit of intelligent risk. Many organizations are doing that as an inclusion in their lean daily management, right? So you're looking every day at how can we make a meaningful change, and then you're leveraging that. So
Ben,
innovate.
let me just focus on that dot point, if you would, as we create an environment that supports and encourages innovation. That one is so important, because we can't make people feel like they're stupid or they are, they don't know what they're talking about for bringing up ideas. There has to be sort of a risk-free zone, and we have to be able to also fail with dignity. We have to be able to have a situation where it's okay to fail, but we're gonna do it by talking about things and giving it a shot. not just dismissing people. So that's really an important one.
Yeah, and that's, by the way, why innovation and continuous incremental improvement are, while they're different, they're really complementary.
Yeah.
You often, when you're doing continuous improvement, you'll see the opportunities for innovation, and that's what you want. You want, like, what could we do with meaningful change? So Dan and Darren, your thoughts on this?
So Ben, I think you nailed it right on the head when you said that innovation is not about creating this whole new thing. It's not about putting $5-10 million into a new system. It's learning how to leverage what's there already. And, you know, Roger, yourself and I have spoken about this before, in my opinion, of you've got an array of technology supporting your organizations already. It's how do we look at it differently, and how do we take what we have there already and leverage it differently to present us with those ideas for improvement. Over the past couple of years, we have in countless facilities and systems have we gone in and just looked at the data a little differently, looked at the flows a little differently to find those places where things are holding up in the process that's preventing that throughput. And what we found is that some of the best ways to solve that came from the folks doing the role. You know, Ben, you mentioned, you know, listening to people's ideas. Roger, you mentioned a safe environment. You know, use the old adages, you know, the suggestion box, the process improvements, recognition and rewards for people who come up with ideas to improve these processes so they feel they're engaged and part of the process. But quintessential in this whole thing is understanding that a lot of the notes you need are there. You just need to get them in the right order by looking at that data differently and looking at it consistently. You solve one problem, you have to solve the next and the next and the next, and keep just moving along that line to improve that throughput and to improve the way the process runs based upon managing with the data. You have to manage through your data to see and create that visibility that's in your system. Dr. Vasila is going to comment now because I just stole his vernacular in the managing through the data. So I'll let Dr. Vasila.
No, I whenever it comes to data, Dan, I will defer to you. You are the expert. No, I think I just echo everything that's been said. And the thing that comes to mind here with me, I think, are just pure good management and executive techniques. You know, I think we have in the healthcare industry done things the same way for a long, long time. We're federated organizations. We have lots of different departments with independent capabilities. We correlate, we meet, we committeize, and we do, you know, what we do. And a lot of times we just kind of go back to the old way of doing things. And when I think of this word innovation, I think, okay, how do we break from the norm? How do we not settle for the status quo? To Dan's point, you know, does it take us going out and buying another $100 million system? No. We've got the tools. Maybe we go out and we get some people to help us use them better, or we get something that convenes existing systems together a little better. But innovation, to me, is that not settling for the status quo, and that we break away from that tendency. And I attend these meetings as well. You know, you get in a meeting that has 10 different departments in it, and you go a mile wide and an inch deep, and you talk about the same problems that existed the last time you got together, the previous month, the previous quarter, and you don't make much progress, or you just talk about how you're working around it. And if it isn't, you know, a dumpster fire at that point, you live with it and move on. So how can we pick targeted areas, or an area, a single area? And instead of going mile wide, inch deep, let's go a mile deep. And let's look at that. Let's know the problem. Let's know what the impact of addressing the problem can and should be if we take a look at it. Have a method, once we set up and go and dig into it, have a method of measuring the impact and measuring the amount of change and ultimately sustain that change. So again, to me, innovation is looking at existing problems in innovative ways, as has been said, rather than thinking up something entirely new, going out in left field, or buying a really expensive new system.
And Dr. Vasila, the word sustaining that change is key. The Band-Aid fixes, the quick fixes, it's sustaining that change for the long term to build upon. And that's a key point in what you just delivered.
You know, thanks, Dan. Sometimes all it takes is asking questions and saying, why is it this way? You know, could it be done differently? The answer is not in, as Dan and Dr. Vasila have talked about, it's not in, if we think that our Epic system has all these modules we haven't quite implemented yet, they're sort of collecting a digital dust or whatever, we haven't used them. That's not the answer. Probably the answer, as Dan keeps telling us, is pay attention to what you already have, maximize it to its fullest extent, and make decisions based on information you already have.
Yeah, so Roger, that is the natural transition to what Gartner's guidance is on this, and that is, how do you progress from that traditional federated, sort of siloed based operation, which is also how we use technology, to more of a real-time health system? And what they're saying is, you try to think about, how can we make the hospital as a smart machine? How do we get real-time data and analysis, convert to intelligent operations, create real-time situational awareness where you're seeing all of the assets that you have across the enterprise in real time, and be able to get the patient in that right location. Like, instead of just bedding them, if you have a cardiac patient, for example, that is coming in, maybe they would do really well in the cardiac service line, right? So, but I don't know that if I don't know what the accessibility is. So what Gartner is saying, as the viewers can see on the right there, is it's about staying up to date. The way they look at it is that this movement is a technological based change arising from the electronic health system, the EHR centric era, and bridging to the longer term area of precision medicine and digital care delivery. And a lot of health systems now are all over digital front door and trying to make it much easier for consumers to come in. The benefits are that it focuses on delivering value to health consumers while fully exploiting, like what we talked about, the organizational benefits of more streamlined, efficient orchestration for care teams and managers. And the way it's done, that Gartner talks about, is that the architecture then has to fully support the notion of composability. And Darren, you leaned into this a little bit, but for the audience, composability is a system design principle that essentially deals with the interrelationships of components. So a highly composable system provides components. Again, this is where innovation comes in. They can be selected and assembled in various combinations to satisfy that specific user requirement. By doing that, and not just accepting technology as it is and assuming you're going to get something out of it that it actually wasn't designed for, you could progress, this is Gartner's point of view, progress to being a real-time health system. So again, Darren and Dan, your thoughts on that?
Well, I'll tell you, I certainly appreciate this this Gartner view and their real-time health system concept. I've only had to see it about 50 times before I think I've started to even understand everything that's going on here. I feel like it's a parable, and the more I read it, the more I can peel back the layers and understand the different levels underneath it. But yeah, it's interesting. The two ways that I think about this with respect to this idea of the real-time health system is, one is how are we managing? How are we engaged in our system in a way that's informed and connected, and we're making decisions in a timely fashion, rather than, again, the way that we have done it so traditionally is we find out about things a month to 3 months after they've happened and try to make adjustments even after the water has gone under the bridge and down the river and is out into the ocean. The other thing too is, how do we make accessibility to care and our decisions on a clinical basis more real-time, more solid, more proactive? And just a couple of things that really come to mind. And again, I know everybody deals with this, and we all deal with it, likely with workarounds and looking at each other from across the table and saying, well, yeah, we wish this were better. But, for example, we have become slaves to our EHR system. I can't think in some ways of a better example of the tail wagging the dog here, because you bring in the technology, you have all sorts of compliance goals that you're trying to hit, whether you're working with DNV or JACO or somebody else, and they're looking in at the data in the EHR, and if it isn't there, it didn't happen. So everything you do boils down to, did you follow the guideline in the EHR? Did you document it in the EHR? Were things done in a timely manner? And then you start to look under the hood as to, is our EHR actually working the way it's supposed to? Like, for example, I've got a patient in the emergency room, And as a hospitalist, I've been called by the ER doctor for this patient who's, got a SOFA 3 score of 9 and needs to go to the ICU because they're in septic shock. And for compliance, a lactic acid was ordered in the ER and has to have a reflex lactic acid done, within an hour or two to meet compliance and have the scores done. And they start things in motion in the ER. And then we admit the patient. All the ER orders get dropped. We put some orders in transition that didn't get communicated to the lab because we didn't know whether the patient was in the ER and it's a nurse collection or they're out on the floor and now it's a phlebotomist collection. And then we go to that meeting on a quarterly basis and we look at each other and we bring up all of these incidences of issues that are happening because we're disconnected within our own organization. And we talk about how great it would be, what the ideal would be, what the impact should be. And then we throw up our hands because we have to run this up 5 levels out of the hospital, the division, the market up to corporate to get any sort of change done to our platform that everybody's using across a 20 hospital system. So again, as I look at the processes we're building and the way that we're becoming more mature as systems and kind of can get to that level 5 and beyond of performance, we really have to stop accepting the status quo and look at where we've made our investments and clean those things up so we can get by the nuisances and stop having things fall through the cracks and be proactive instead of reactive. Hopefully that's a good example. But
it's an excellent example, Darren. Thank you so much. And I would just pose this to you and Dan. It just occurs to me, is there, by the time we have that quarterly meeting, just think of the number of dollars and the number of extra days, the extra costs, all that stuff. Is there somebody who can look at all this and say, you know what, we're getting all this stuff done in series rather than layering it, doing it at real time? Is there somebody who can pull the cord and say, stop, this isn't working the way it should? But instead we wait till the quarterly meeting. Is there an answer to that?
Well, I'll give you my input on that. I would say absolutely yes. And that's, not to put a plug in for what we do at About, but this is, this is what we do as we go in and we do assessments with organizations. I think as a third party coming in and working with an organization and having accessibility across the silos to many areas with a feeling in mind of the organization that you're coming in as an unbiased assistant to this that's going to work across those organizations. I mean, I'll shout out kudos to Dan here. I've seen him go into multi-hospital systems, get the data that they already have within their system, make sense of it, and then present it back to them. And then the plan just evolves out of the data-driven management of how you move forward in the organization. So I would say a resounding yes to your question. And the good thing about it is most of, if not all of the data is already there to analyze. Yeah. It's just a matter of making the concerted effort in the right way with somebody who knows what they're doing.
That's great. So Dan, I just wanted to modify that question from the standpoint for the audience of what they could do, because I really obviously appreciate what Darren is talking about, but from the standpoint of what they can do, what is the sort of essential triangle, or for lack of a better word, of alignment for them to be able to be successful in terms of getting stuff out of their system and using it?
So Ben, you and I have had the opportunity to talk about this model on multiple occasions, and Dr. Fusillo and I have discussed this. And when I'm looking at hospitals and I'm looking at their operations as an industrial engineer, you'll often see pieces and parts of this in play. To Dr. Fusillo's point, they're often waiting until that monthly meeting to review the outcomes versus assessing the situation in real time to react and change it going forward, pulling the stop on the production line, as it's known in the industrial engineering world. And what we see to be highly effective in this is, and Roger, you and I have spoken about this, is really that triangle of expertise, I like to call it, where you have got a very strong operational person who understands the workflows and the operations of the hospital, partnered with a data person who's looking for those opportunities. When they get that sniff of a problem, they have that space to put it out there and say, hey, we should look at this. And then the third part of that triangle, which is quintessential, is a clinical person involved in the process design. Because you can look at data all day and you can have an industrial engineer tell you the most efficient way to do this. But without that clinical patient safety spin on that, it's meaningless in a hospital system. Putting those three things together in this real-time health system, which allows you in real time to have what's going on, where is that patient sitting, and the situational awareness of what should I do next, which is where your clinician comes in, and then having the operators to make it happen. Adopting this model as a smart machine is highly effective, but it has to be done simultaneously. If you do it here, then you create the situational awareness, and then you create the intelligent operations, you're going to miss those opportunities for months, if not years. So it's being aware in the present now with those people who know what to look at and what to look for.
Yeah,
Would
that
be my
makes
best answer on that one, Ben.
yeah, that makes good sense. So this one's interesting, Roger.
Yeah, level set for us, will you, Ben? And you know, again, what will it take to succeed? Not just to survive, but to succeed.
So I think working off what Dan just said, there is really this operational maturation that goes on, but it has to be pretty rapid cycle. So there are four components to this. The first is network integrity. We talked about when we were opening the challenges and the erosion of network integrity because of outside competitors. So the idea is you have well-established clinically integrated network, your ACO. You are working to leverage all of those resources across your health system. They're well-established. They've got good accountability mechanisms, ensuring streamlined interactions, multiple or mutually beneficial transitions, and optimal patient outcomes. And then you have the people, process, technology thing. So everybody understands that, right? Conceptually, that it's three-dimensional, people, process, technology. But let's just unpack that a little bit. So from a process standpoint, it's that the processes are aligned, that to Dan's point, they're transparent, they're efficient, and as much as possible standardized across your core functions, including your post-acute care transitions. And the reason that's super critical is because there is, it's well known in the Lean Six Sigma world that I work in often, that there's about 40% waste in systems. So imagine if you're taking 40% waste out of processes, what that means to your short staff. Because now they're not making a bunch of phone calls, they're not running around trying to get information and data. Instead, you've lined it up as best you can to have really efficient handoffs and so forth. Then you go to technical integration. So technology, as we've been talking about, enables automated processes and secure communications for efficient patient placement with accessible data insights and for continuous improvement. And then there is the people side. So it's building their capacity and their capability to really understand their roles and their responsibilities and collaborate then across the silos and silo spanning functions, and really being empowered individually to drive positive results and improvement. That's the baseline, right, for operational execution. So this particular guidance is pursue that operational maturation in addition to the innovation, in addition to what Gartner's talking about with progressing the hospital to being a smart machine through the composability concepts.
Ben,
There's
oh, go ahead, please.
no, please go ahead, Roger.
Well, I was gonna just play my facilitator role and say we've got 20 minutes left, and we've got some questions. I just want to, Ben's driving the slides, and I just want to remind you of that. And we've got so much more information. So
yeah, here's what I'm wondering, Roger, because you asked as a part of the prep for this, like, guys, let's make this super practical. Can you go through a practical example? Do you want me to just
let's go to the case study? Yeah.
Okay. All right.
Yeah.
Let's do that.
Is that all right?
Yeah, absolutely. And Dan, jump in because you were just going to say something. I don't want to.
Yeah, I was just going to say on that last slide, as you look at that maturation slide, I mean, there's a lot on that page. And the one piece I would say from an operations perspective is find what matters in each of those buckets and define those simple key measurements to keep it simple to monitor how you're doing in that matronation. And as Ben gets into some of these slides, he's going to talk about some of these key measurements. But I want you guys to keep in mind, when you're measuring your operations, see where you are and where you need to go, keep it simple. There is so much data that is overwhelming us sometimes that we don't know what to act upon and not act upon. Identify those key measurement points and focus on those. Those will lead to other improvements and other measurements, but define what is success in those 4 areas of the team, the integration, the technology, and the network. Define what matters on those and keep them in your line of sight at all times.
So perfect. That actually, sorry, Roger, I didn't mean to interrupt you.
No, great. Great advice, Dan. The simplicity of it is really important because it does get really complex really fast. But go ahead, Ben.
So that goes right to number 5, right, Dan? Yeah. It's focus. It's like you've got these big challenges, capacity, staffing, cost coordination, but at the end of the day, you have to really know where to focus. So in answer to your question, Roger, what we're going to talk about for the case study is just the standard process in a hospital. The audience saw it unfold as Dan was talking. So there's an admission process, there's a care, access, diagnosis, treat process, and a discharge. It all looks so simple on the screen. Not so much, right? It's actually super complicated. So when we talk about the case study type of an example, get to this slide, what you're doing is you're identifying where you want to get to. So in this example, it's how do you mature your command center, or in this case, an access center, to be able to have a huge impact on that kind of flow. So there are obviously required inputs. People can see that here. There are a lot of different ingredients within the access center where you have functional requirements that are connected, and you have collaborators like the ED, physician partners, inpatient nurses, ancillary community partners, and then you have very clear performance metrics. So this is all a part of what Dan was just alluding to on the focus. And so that when you are looking at each phase of that typical journey, you're looking at what are the expected outcomes within my access, or what are the expected outcomes within my progression, or what are the expected outcomes within my transition. And maybe for sake of time, if you want, Roger, should I just keep going with the
fire away,
and then we'll circle back. Okay.
Yeah.
All right. So what you're looking at then is, with focus, is if I'm looking at demand or access, I want to be able to say yes. Like if a patient reaches out, I want them to come to us, not go to somebody else that's a competitor. So how do I make yes easy? How do I better manage the volume of requests? How do I achieve the right patient mix? And I'm probably going to be looking at things like, then I want to measure request volume. I want to measure admission volume. I want to look at declinations. I want to look from time for request to placement. And here's the outcomes that I expect: an increase in equitable access to care, enhanced market share, increased patient safety and revenues, and so on. I'm not going to go through all these, but you get the idea. What you're doing is you're taking what is, you're looking at how can we best align all these functional components, and then zero in on our priorities, KPIs, and outcomes that we expect.
And Ben, just before you go,
yeah,
I would just
please
encourage our audience, if you need motivation, if you're lacking motivation to do some of these things, to act, start with the outcomes and work backwards.
Exactly. Yeah, exactly. And by the way, that leads right here. And Dan, this is your wheelhouse. So, talk to us about this in terms of the criticality of data and insights as you're doing this journey.
Oh, you're on mute, Dan.
Yep, sorry about that.
Yep.
So when you're looking at your data, you're really looking at 3 aspects of your data. You're looking at your analytics. Your analytics are really giving you the what. What is going on in my operation? Where do I have opportunities? Once you get that top level of your analytics, that's where you need to start getting into the why reporting. That's where that data analyst role, that data strong person comes into play to say, why is this happening? Here's the outcome I'm looking for. Here's how I'm measuring it. Why is this number not where it needs to be? And that's where you start getting into your analytics. And that's where the gold is. That's going to tell you why something is happening and the pivot you make to your process improvement to make it go away. But your analytics and your dashboards, they need to tell you what's going on so you know where to see, what to dive into. These are just examples that we put out there to gain insights in some of our operations on workflows, on time spend, and then also on the right-hand side, our efficiency on certain service lines where we're spending the most time for the least volume. Understanding those things in our operations help us know where to go and where to focus. Get to the what, then start looking into the why with your data.
Yeah.
Dan, is it fair to say that everyone, just about everyone listening who's invested in an EMR already has this data? They just perhaps, when everybody's responsible, when everybody's an owner, nobody's an owner. They just need help being able to.
I've gone into the EMR is going to really give you most of the data you need. Some facilities have something that brings it together a little better than some other facilities do. But understanding and knowing where your data is and how to present it is a key attribute to all these improvements we're talking about today.
Great. Thank you.
And so what's interesting is as you're going through this operational maturation, so in this case study example, you start to see certain things coming out. You have expanded breadth of your care setting services. You're able to see those up front and manage them in real time. You have improved visibility across your operation and optimized decision support because of what Dan was just describing, and then enhanced care team interactions, which reduce workload and improve employee satisfaction and so forth, all because of that. So, for example, recently we were talking to a health system in New York City, 13 hospitals. And the challenge is they're an Epic shop. They've invested a ton of money and they really feel like they need to get the most out of that, which makes perfect sense. Most health systems are exactly in that situation. So we came alongside from a composability standpoint and said, look, how can we do something better than free? In other words, let's help you figure this out with your consulting partner and just help you leverage the technology. And when we did the ROI modeling, they would get a return on investment equivalent to their cost input in 3 months. So going back to what you talked about, Roger, at the beginning, the financial pro forma of what's going on right now in health systems doesn't give organizations a lot of time. So being able to use this kind of case study stuff is I think what you were trying to bring to bear, as I understand it, for the audience.
Absolutely. Yeah. We don't have much time, but you probably have more tools than you think, and it can be cost effective, which is really important right now. So, we talk, Ben, you and I talk a lot about, so what are we trying to get across? So this is the situation. Now what? And then finally, so what now? So now what? What do we do in response?
So I think based on what we talked about today, organizations are not going to go wrong if they follow the Baldrige guidance on innovation. And that's just really looking for meaningful change and correlating that with your improvement efforts like lean daily management. Being able to create a real-time health system using the guidance that Gartner has and being able to create a composable solution and not just assume that your EMR is going to do it all, because it doesn't. And you don't have time to mess around with that. So how do you do it in a way that's better than zero? It's better than free, essentially. And then how do you pursue in that process operational maturation? And this tree on the right-hand side sort of represents how a healthy, high-performing operating system, right? It's grounded in its roots or its mission, vision, and values. Its growth and development is based on a disciplined process of how to get things done. And the sap of the tree is our statement of purpose, why we exist as an organization. The trunk then is the fundamental business strategies or pillars. The core branches are really those priorities and objectives that we set at health system. And the distal branches are the initiatives and the action items. So all of that is a part of the tree. But what we really want is the fruit. Like we really want apples. Like we really want to be able to accomplish what we set out to accomplish. That's really what we're talking about, right? And it's there's no really fast way to do that. There's just a right way to do it. And so the logic here, I think, in what we're talking about is you won't go wrong if you innovate. You're not going to go wrong if you're working towards creating a real-time health system with composability. And you definitely are not going to go wrong if you pursue operational maturation in a really practical way. You can get to return on investment responses and improve consumer support in literally in months.
Yeah.
Ben, everything that's been laid out here, I think, is so important and strategic. The way that people think about things, the way they lay them out, because it drives you to making practical decisions in very specific and focused areas. And I know we're going to have some Q&A, and there have been some questions that have been sent in. There was one question that was on the Q&A board that I just read. I thought was a great example of this very thing. The question asked was, and I think this probably came through when we were talking about the nursing shortages and the capacity restrictions, but this was posed by John Rudnick, who said, more nurses are being trained, however, more want to leave the bedside and pursue APP, CRNA, and midwife roles. Is there an opportunity to design a role similar to what they do in the military with a corpsman or core wave role to ease the pressure on staffing and entice more to the bedside? There are obvious legal and professional considerations. This is an exact example of, hey, let's take a specific issue, apply an analogous situation, and see if there's something that we can do here. As I've looked, for instance, and of course, several months ago, we had a couple of chief nursing officers on for one of our podcasts who talked about some of the practical things they were doing to keep nurses from going through burnout. Boy, tough time those nurses came through, having to don the hazmat suit every time they went into a COVID room. And if you've got 3 or 4 of those, you're just living in that thing all day long. So there was a lot of burnout. There was a lot of need to step away and have a little bit of a respite and recharge your battery so you could, come back onto the wards again. I think John's question here is great. How do we ease the pressure on staffing instead of just calling the same nurses back to work overtime in those very intense environments? I remember some of the practical, responses that were given of creating hybrid roles, of spending time on the wards and off the wards with some of the work that you do. So it's not always the same highly intense environment. There are new roles in nursing with not just RNs, and I know LPNs kind of went by the wayside. They've got registered practitioner nurses now and other roles that can be leveraged back in the hospitals and are considered more approved to take care of some of the tasks that free up our RNs to focus on things, getting everybody to work at their the top of their license. I even had a conversation with a company the other day that not only provides telehealth and EICU, but telesitting. So you can wheel a computer into a room, and they have a telesitter there that's watching that patient. And man, everybody knows the impact. If you've got a one-to-one patient, you've got to take one of your RNs off the floor and put them on a one-to-one to just sit there and take care of the patient. So I think there are fantastic opportunities to make nursing more accessible to those who want to stay or who we want to stay in the hospitals, as opposed to pursuing all of these other things, such as working at home for a payer and doing surveys on the phone or doing peer review calls.
Darren, and we would be remiss, by the way, for those healthcare leaders who also recognize that the challenge is to also create a good culture internally, the best they can, to keep it attractive and reduce exit of nurses and to attract others to come back, which is a lot of what we're talking about as well, right? In other words, if we would help reduce the chaos, create a culture of improvement where they have a voice and they have their handprints on it, combined with what you're talking about, it has to be comprehensive solutions. I think well said.
Yeah. Great question, John. Thank you for that, and great answer, Darren. And just a shout out to anyone who served as a corpsman in the military. What a great, these are just fantastic individuals, and I've known several healthcare administrators and presidents who started out their healthcare life as corpsmen. So thanks for that question. Jerry, I think we have a couple of others, don't we? Access to those. So let me just ask those then. So let me just ask, is the real-time data and reporting that you demonstrated in the Access Center example, Ben, coming from just that system, or is it pulling from applications across the health system?
It's pulling from applications across the health system. That's what that composability is all about, Roger.
Yeah.
Right.
And
In
one
other
other
words,
thing go ahead, Ben. Sorry.
Sorry, it starts with what are you trying to accomplish, right? In other words, what are the KPIs and results you're trying to accomplish? And then you go back in and say, so where's that data? How do I get it? How do I make it visible and usable within an integrated and efficient process?
And the thing I would add to that too, Ben, is as you look at that data, bringing it together almost creates new data, metadata, as they align together. And there's such an opportunity as well in operations, like in an access center, where you have people interacting with the systems and with other providers to gather data that sometimes is lost in the shuffle and completes the picture. So novel data that's being entered in, data, to your point, that's coming from a variety of other systems, and then the context-rich data that emerges from all of it as it's brought together.
That's great. That's great.
And the
We did
quintessential
have-
piece of that, Dr.
Oh.
Vasillo,
Please, Dan, go ahead.
the quintessential piece of that, Dr. Vasillo, that you're saying is what I see often is I see people looking at silos of data and not looking at the flow of the patient. And understanding that flow holistically is the key to finding these opportunities. Dr. Vasillo nailed it. Looking at the data in these silos and pieces parts almost causes problems. When it all comes together and shows that flow, that's when you're really going to start finding the nuggets in that data.
I love the composability example, and just really, I have a 16-year-old grandson who's quite a gifted musician, and he's composing music, and he'll call me and say, he'll pull a guitar line and he'll play it, and then he'll say, and I think it needs bass, so he'll add a bass line, and all these, he's got the melody and the harmony and all this stuff, and all these pieces together are interesting, but not really, but once he layers them all together, I go, oh my goodness, that sounds fantastic. And I think that's what we're talking about. We're trying to,
It is.
layer all this information together to make the very best decisions and to make music, in the health system for the patient and the employees. So great. Hey, one last question, and will copies of the slides be available? It's up to you, Al, to us? And
Okay.
go ahead.
Well, as a
Jerry.
reminder, the Foundation's Institute for Performance Excellence has numerous training and professional development opportunities offered online and at your own pace. This week, we were able to unveil 380 new certification courses. Thanks to everyone for attending today. As a reminder, again, the recorded version of today's presentation and slides will be available on the Foundation's website early next week. And once again, thanks to all of our sponsors who make presentations like today's possible. I want to thank all of our guests today, Dan, Darren, Ben, and Roger. Fantastic and very engaging presentation and discussion. Look forward to seeing everyone again at our next CEO virtual roundtable. Thank you and have a great day.
Thanks, everyone. Take care.
Thanks, Roger. Bye-bye.
See you guys.